What's up, Ninja Nerds? In this video today, we're going to be talking a little bit about syncope. This is a part of our clinical medicine section. Also, just real quick, if you guys like this video, it helps you, it supports you, please support us. And you can do that by hitting that like button, commenting down in the comment section, and please subscribe. I really urge you guys, if you guys have a moment, a quick second, take it and go down the description box below. There's a link to our website. On there, we have a lot of cool stuff that we can offer that's not here on our YouTube site. So we have things like notes, illustrations. We're even developing some exam prep courses for those of you preparing for step 1, step 2, PANCE, etc. So get ready and keep your eyes peeled open for that. Plus, check out some merchandise, get yourself some swagoo. All right, without continuing on about that, let's talk a little bit about syncope. So syncope is a patient who has a transient global hypoperfusion to the brain where they have a transient loss of consciousness and they can quickly return back to their normal baseline. So that's the concept of syncope, is where a patient has global hypoperfusion, a transient loss of consciousness, and then quickly back to their baseline. The question then becomes, what causes the global hyperperfusion? That's really what syncope is all about. So when a patient syncopizes, they come to the hospital, you have to kind of figure out what was the reason behind it. Oftentimes, history and physical exam is the key. But let's go through here. There's 3 types: reflex syncope, orthostatic syncope, and cardiogenic syncope. Sometimes you may hear this one listed as kind of a neurocardiogenic syncope, and it actually makes sense here and why in just a second. But reflex syncope is actually an umbrella term for 3 different types of syncope that kind of fits in the causes section. It's a vasovagal, a situational type of syncope, and what's called carotid sinus hypersensitivity. I'll explain all of this in a second. The concept behind reflex syncope is really interesting. There's some stimulus, and what this stimulus is doing, let's use this color here real quick. Here's going to be your vagus nerve, right? The dorsal nucleus of vagus. And it'll send down this information via the vagus nerve. And what the vagus nerve will do is it'll act on your vasculature, and it'll act on the heart. And what it'll do is it'll release what's called acetylcholine, right? So here, let's actually mark this down here. This is actually going to be cranial nerve, which is the vagus nerve, the 10th nerve. So cranial nerve, 10. It'll go to release acetylcholine onto the heart. And what it'll do is it'll exhibit 2 types of effects here. One is what's called a cardio-inhibitory effect. So this is called a cardio-inhibitory effect. And what that means is acetylcholine will actually hit some of the muscarinic receptors on the the actual conduction system, and slow down the heart rate. So patients will actually develop a reduction in their heart rate. When you drop a patient's heart rate, what will you do to their cardiac output? You drop their cardiac output a little bit, right? And if you drop their cardiac output, what would you potentially do to their systolic blood pressure? Drop their systolic blood pressure a little bit. So these patients can exhibit, as a result here, from dropping their heart rate from that vagus nerve input or outflow, they can drop their heart rate, drop their cardiac output, and drop their systolic blood pressure. All of these can happen as just one of the effects from that vagal outflow, because this puppy is on hyperdrive. So we're going to kind of say that it's really it's actually inhibiting it, but here, we'll just say that this puppy is this dorsal nucleus vagus is really on hyperdrive. That's one effect. The second effect here is on some of the actual parts of your vascular system. And it'll do something called a we'll actually put it like right here. We'll put a vasodepressor effect. And what this may do is this may either shut off the sympathetic nervous system, amplify the parasympathetic nervous system, but basically what happens is your vessels will actually start to dilate. And so now because of that, when I actually get this vasodilating effect, what does that do to my systemic vascular resistance? Well, I increase the diameter, so the resistance should go down. When your systemic vascular resistance goes down, what will that do to your blood pressure? It'll drop it. It generally will drop the diastolic blood pressure, but that's what you're going to see, is you're going to see a drop in the resistance and a drop in the diastolic blood pressure. As a result, you're going to see a drop in the blood pressure. In complete concept here, when you drop the patient's blood pressure, what will you do to their actual perfusion? It's going to reduce. So as an effect of both of these, look what starts happening here. As an effect of both of these, you're going to decrease your cerebral perfusion. And now, if you reduce your cerebral perfusion, what did I say was the definition of syncope? It's global hypoperfusion that then leads to less blood flow going to the brain. And what will the patient have? A loss of consciousness. And we're going to put a transient loss of consciousness. That's the concept here. So there's vagal nerve outflow, cardioinhibitory effect, dropping the heart rate, cardiac output, and blood pressure. Vasodepressor effect, dropping the actual systemic vascular resistance in the blood pressure. If you drop the blood pressure in general, you drop the cerebral perfusion, they'll have transient loss of consciousness. The question then arises here, which is very interesting here, which is why in the heck is this vagal outflow so intense, right? And there's 3 reasons why the vagal outflow can be super intense. One is called a vasovagal response. So what do I mean here is that the patient is usually, in some way, shape, or form, having lots of pain. There's some particular phobia, or they have been standing for a very, very long period of time. When there's lots of pain, a phobia, or prolonged standing, what this will do is this will activate your vagal outflow. So remember that vagus nerve, which is right here? This puppy becomes super activated and goes down and does everything that we talked about before with the cardioinhibitory effect and the vasodepressor effect. This is the concept that I want you guys to understand. So if you hear within the history, they had, they stabbed their foot or something like that, and then they passed out. Or you showed them a spider, and they have a phobia of spiders, and they passed out. Or they've been standing for long periods of time at a concert, and they passed out. That's a perfect example of a vasovagal syncope. And you don't really have to go much further because the history really suggests it. Situational is a little bit different. It's very interesting. I don't know what the heck this thing is right here. Let me fix that. But situational is usually due to some type of straining event, right? So usually what happens is you see in the particular scenario, a patient has been like coughing and coughing and coughing, and then they syncopize because they're straining. And that can really activate the vagus nerve. But even a bigger one is micturition. So when a patient is trying to actually go to the bathroom and pee and pee and pee, sometimes what that can do is that really can activate that vagal nerve outflow for some weird reason. So ask the patient, did they pass out after they were having a terrible coughing fit or while they were trying to really force themselves to urinate? The last one here is really interesting, and this is usually due to a carotid sinus type of compression. So you have to remember here, one of the inputs to your actual central nervous system is you have here your carotid sinus, right? Here at the carotid sinus, let's actually make this a lot better. This is a really ugly carotid sinus. Let's fix that here. Here we're gonna have the carotid sinus. Here we go. And that will give you your external and your internal kind of carotid arteries. So common carotid, internal, external, and then right here on that sinus area. Here, there is these like little areas, these little like receptors, these pressure receptors. And so sometimes whenever you activate these can, through some weird way, kind of connect with the glossopharyngeal nerve and the vagus nerve. And guess what these can go and do? They can activate that vagal outflow. So if you compress these, so the whole concept is you have to compress these. That'll activate it. That can trigger this vagal outflow. What are the things that will compress it? One is when you do a carotid sinus massage. They do this a lot in patients who have SVT. So their heart rate's really fast and you really kind of mash on that. That's gonna compress this, send vagal outflow, and drop the heart rate, hopefully. So one of those would be a carotid sinus, that was an ugly one, sinus massage. Pretty cool. I would say try to avoid this one in true reality for SVT, but nonetheless. The other one will be a tight collar, believe it or not. If you're going like straight, like tight collars whenever you're wearing like a weird polo, that could be one, or a button up. So tight collars. Another time that I've seen these is sometimes in patients who are shaving. So when they're shaving, that could also be another way that they're doing that because they're applying pressure over that area. And then the other one is head turning. So again, you really want to try to ask the patient, have they had any syncopal event from a carotid sinus massage, wearing really, really tight collars, shaving while they were doing it, or turning their head, and that also caused it. These are all things that are going to activate the vagal outflow, depress the actual, cause the cardioinhibitory system to become activated, and the vasodepressor system to become activated. All right, Let's go to the next one. The next one here is going to be orthostatic syncope. This is actually a really, really interesting one, super, super common. The concept behind this one is you have a patient who is usually in some way, shape, or form having a reduction in venous return. That's honestly the biggest concept. So you know blood is supposed to run here, right? So it'll run out from the arterial system and then come back via the venous system. And then naturally it should come back into the heart and fill, generate a good cardiac output. But in some patients, let's say that this pathway is affected. And so because of this, let's say that they have a very low venous return, all right? So they have a very low venous return. When venous return is extremely low, you don't fill the heart. What is that called whenever you have less filling of the heart? So if you have less filling of the heart, you have a less preload or a EDV, right? Because of that, if you drop your preload, you drop your stroke volume, you drop your cardiac output, and you drop your blood pressure. So all of these are kind of making sense, right? So if you drop your venous return, you will subsequently drop your preload, your stroke volume, your cardiac output, your blood pressure. Let's fix this one. It's an ugly looking arrow there, preload. And then if you drop your blood pressure, what will happen to the actual cerebral perfusion? It'll be reduced. So as a result here, your cerebral perfusion will drop. And if your cerebral perfusion drops, then I'm not getting enough blood flow to the brain then, right? And then as a result of me getting less of this blood flow to the brain, what will then happen as a response? The global hyperperfusion and transient loss of consciousness. So this would be the effect here, and we'll actually kind of just mash this up here, unfortunately. But this will be the transient loss of consciousness, okay? Now, question then arises, in this scenario, which vagus outflow is increased, we figured out the causes for that. Venous return is low, we got to figure out the causes for that. Reasons why the venous return would be low is usually three particular reasons. One is your volume within the vessel is significantly depleted. This is relatively common, right? So like this is really, really common. If a patient has diarrhea or vomiting, they're not absorbing that fluid. If they have peeing tons and tons and tons of fluid from their kidneys from diuretic abuse, that could be another reason. Or if they have burns or they're sweating like a banshee, that would also cause them to lose a lot of fluid. So if they're losing fluid from all of these sources, or what's another way that you could lose fluid? Not as common, but it would be terrifying. Bleeding. So if it's from fluid loss or blood loss, what is that doing to your actual blood volume? It's reducing it. So these patients will have a reduced volume because all of their volume is being lost from these organs or from the blood vessel itself. When you drop your blood volume, we're going to abbreviate BV, you drop your venous return, my friends, and that will then subsequently lead to that orthostatic change, which is you'll have a transient type of launch of consciousness due to global hypoperfusion. All right, that's one concept. Another one is you're dilating the vessels. So if you dilate the vessels, you actually reduce the systemic vascular resistance, and that reduces venous return. So the whole concept behind this one is, same thing, you're reducing the systemic vascular resistance on the veins. They're not squeezing. Normally, veins are not high pressure system, and they usually, it's just gonna be a slow flow. But if you squeeze on the veins, you can push the blood flow up to the heart. Well, if you're not squeezing at all and they're really, really relaxed or dilated, that venous return is gonna be significantly reduced. So a decrease in the SVR will then reduce your preload or your venous return in this particular scenario. Now you have to then ask yourself the question, what are the things that are causing this vessel to become super dilated? It's dilating drugs. One is going to be your calcium channel blockers. They love to do this. And then your alpha-1 blockers. So calcium channel blockers, this is going to be drugs like nifedipine, amlodipine, right? Alpha-1 blockers will be things like tamsulosin, prazosin, doxazocin, etc. These are going to cause the vessels to dilate. In other words, their systemic vascular resistance is low. They're not going to get a good venous return. Last one here is autonomic neuropathy. This one's really interesting. It's not the vagus nerve that's being affected. Let's use this color here. We're going to have some sympathetic nerves that should be releasing things like norepinephrine and epinephrine, etc., which should cause the vessel to venoconstrict. If you constrict it, the resistance goes up, you squeeze blood up to the heart. Good venous return. But what if I jack this thing up, or I jack up the central part of it? So now I have a neuropathy that's actually present, and it's not sending these signals, so there's a reduction of this. As a result, there's a reduction in the venoconstriction. If there's a reduction in venous constriction, the SVR goes down, and the venous return consequently goes down. So does the preload, so does the stroke volume, the cardiac output, the blood pressure, and then boom, patient's on the ground. So these are decreased venoconstriction mechanisms, just drugs versus neuropathy. This one is your volume down. Okay, we come to the last one here, talking about the pathophys and causes here. Cardiogenic syncope. In this particular scenario, it's actually relatively straightforward. It's not a message that's actually coming. So you kind of noticed here that in this one, there was no real message from the brain to the actual cardiovascular system. In this one, it was the message from the brain to the cardiovascular system. This one was a message from the cardiovascular system to the brain. This is going to be the same thing, a message from the cardiovascular system to the brain. So what do I mean by that? In this scenario, it was a reduction in venous return. In this one, it's a generalized drop in cardiac output, and that could be a bunch of different reasons, which we'll talk about. But in this problem, the heart is not doing a very good job of getting blood out of the left ventricle and into your systemic circulation. So there's going to be very, very little blood flow circulating through the systemic circulation. If I have very little blood floating through the systemic circulation, that means very little blood getting to the actual central nervous system. So the question is okay, we know out of this scenario here that there is a reduction in cardiac output. We will talk about all the reasons why the cardiac output is reduced. It's just, it's different in this situation because it has nothing to do with venous return. It's all other mechanisms. In this scenario, cardiac output drops. If cardiac output drops, then what do we know? We know that that will drop your blood pressure, preferably the systolic blood pressure, but in general, we're gonna say blood pressure. That's gonna cause cerebral perfusion to be reduced. If you drop your cerebral perfusion, you will have a transient loss of consciousness that will actually occur, right? So this is the mechanism that we've constantly become acquainted with. It's just in each one of these scenarios, it was a little bit different as how we got to it. Venous return, vasodepressor cardioinhibitory response. This one is there's a reduction in cardiac output. Let's talk about why this is the problem here. When it comes down to a reduction in pure cardiac output from the heart is the problem. It's not the vessels. It's not the venous return. It's nothing to do with the vagus outflow. It's the heart is the problem. There's two reasons why. One is it's arrhythmogenic or it's a mechanical cause. What do I mean? Well, let's say that my heart rate is too high or my heart rate is too low. It may sound super simple here, but whenever your heart rate is too high, what you do is you actually reduce your diastolic filling. In other words, you don't give the heart any time to fill with blood because you're trying to beat so fast. You're beating fast, you don't give it time to fill. When you reduce diastolic filling, you reduce what? Your preload, and that reduces your stroke volume, and that reduces cardiac output. And that's how we got that concept there. So what you'll notice here is that you reduce diastolic filling, reduce stroke volume, and reduce the patient's cardiac output. But you have to really be going pretty fast. Generally greater than 150 beats per minute for the ventricles in order to really reduce diastolic filling. So the time that you would see this is in a patient who has VTAC or VFib. That's why sometimes patients will syncopize in these particular events. The other one is if the heart rate is super low, because this is directly tied to cardiac output intensely. So if a patient's heart rate is really low, we know cardiac output is equal to heart rate times stroke volume. So if heart rate drops, you will directly drop their cardiac output. We don't even have to go through all of this mess. It will directly drop their cardiac output. This would usually be patients who have like complete or like very severe heart blocks. So I'm talking generally like a second or third degree AV block. And their cardiac output is so low that they're not able to perfuse the brain properly. Okay? So that's generally going to be the concept here. Let me fix this. I know Rob behind the camera is actually screaming right now, so let me go ahead and fix this right here. All right.
Much better.
All right, we're going on to the next concept here. Mechanical causes. When we talk about these, it has nothing to do with the heart rate. It has something to do with the true ventricular function. And usually it comes down to a couple causes. One is the contractility stinks. Second, they can't fill. Third, they can't get blood out because of an afterload problem. So 3 things. One is a reduced contractility. This one is usually due to reduced filling, massively reduced filling. And this one is high afterload. So let's write those down. So decreased contractility. So there's something wrong with the pump. The pump is not doing good. Here, you can't fill like massively. I'm not talking like a little bit. You can't fill at all. And third is the afterload, which is the amount of pressure and work it takes to get blood out of the heart is massively increased. Things that would do this, all of these things will drop your cardiac output. I don't need to go through the whole mechanism. This will drop your cardiac output, this will drop your cardiac output, this will drop your cardiac output. But the question is why? Usually this is a massive myocardial infarction. Or it could be if a patient has a very severe heart failure, usually with a reduced ejection fraction. Decreased filling is usually due to tension pneumothorax. So this is because they have so much mediastinal shift that it compresses their right heart and their superior vena cava that they can't get blood into the heart. Another disease that acts like this is tamponade. So these are other scenarios where this would be absolutely catastrophic. You can see how these are much more scary than someone coughing or straining to pee. The last one is increased afterload. This would usually be, this is classic, please don't forget this one, hypertrophic cardiomyopathy in a young kind of athlete. Another disease similar to this one called aortic stenosis. And the last one, I've seen this before, is a pulmonary embolism. HCM and aortic stenosis, it's hard to get blood out of the left ventricle into the aorta. PE, it's hard to get blood from the right ventricle into the pulmonary arteries. And again, you won't get any filling of the left side and you can't get blood out of the left side as well. So these are catastrophic scenarios where your cardiac output drops. To finish up, we have now talked about the pathophysiology, the causes, but one thing I have to say here is that we have to briefly kind of come up with another way of defining the differences in the way that these present. There's no true like complications that are like individualized to syncope, but it is important when the patient presents, you really listen to their story. For reflex syncope, usually the cause will be elucidated, but the way that they say that they syncopize is really crucial. For a reflex syncope, you really want to hear this terminology of a prodrome that occurred before they lost consciousness. What the heck do I mean? They saw a big orangutan running after them. All of a sudden they got diaphoretic. They got nauseous. Their vision got blurry and they passed out. That is a prodrome that preceded the loss of consciousness. That's only critical to reflex syncope, okay? Orthostatic syncope is positional. This is super important. We know the causes. Patient could be hypovolemic, they're taking medications, or they have a neuropathic disease that alters their venous return. Venous return is super important when you're going from a seated or a supine to a standing position. If you do that, you literally depend on those venoconstrictive mechanisms and volume to get blood to your heart. So if you lose that, the patient will then lose a lot of cardiac output and syncopize very quickly. So it's usually a positional change. The last one is cardiogenic. This one is actually scary because these don't give you a prodrome, they're not positional, they're sudden. So this could be 2 ways. We could say here, I can actually put it underneath it, sudden or one other scenario, exertional. And what I mean by exertional is this is classic for your afterload problems, your HCM. So if a patient all of a sudden, no prodrome, no particular trigger, boom, they pass out, you really want to think about arrhythmias. If all of a sudden they're exerting themselves, they're going to be making it harder, especially for this afterload problem, and then they pass out, you really want to think more about the mechanical causes. So exertional mechanical arrhythmia is usually sudden. That covers this concept of syncope. Now let's go into how we diagnostically approach it. With the diagnostic approach to syncope, the first thing that I want you guys to think about is getting orthostatic vitals in a 12-lead ECG. The reason why is this is going to help you right away to tell you, do I have an arrhythmogenic cause of syncope or do I have orthostatic syncope? If I have them going from a seated to a standing position, and during that time frame when I have the blood pressure checks between those two, their systolic drop more than 20 in that time frame of going from seated to standing, that would be diagnostic of orthostatic syncope. Another one would be if their diastolic it was greater than 10 millimeter mercury drop. That would also be suggestive. This last one, not as important, but their heart rate should shoot up as a reflex to this drop in blood pressure. But these are the findings that would be super suggestive of orthostatic syncope. If a patient has an ECG that's abnormal and it shows, hey, they got a 3rd degree AV block or a 2nd degree Mobitz 2 or a 6 sinus syndrome or VTAC or torsades, well, then I've already concluded that it's a cardiogenic syncope of a rhythmic origin. But if their ECG is really normal and I just maybe miss them being in that occult arrhythmia, then I can go ahead and do an EP study or a Holter monitor and see, hey, did I miss that particular arrhythmia? If there is no arrhythmias, but I think that their history is suggestive of a mechanical cause, if it's super obvious, like tamponade or tension pneumothorax or PE, those are really kind of going to be super clinically obvious to you. The ones that we'll probably miss is going to be the ones like aortic stenosis, HCM, maybe the heart failure or the cardiomyopathy. So in those scenarios, I would get an echocardiogram because that's really going to help me to see, do they have a reduction in their ejection fraction? Do they have a low motion abnormality? Is there a stenotic aortic valve? Is there septal hypertrophy? These are great things to rule out the mechanical causes of cardiogenic syncope. Now, if you've done this and the ECG is normal, their orthostatic vitals are normal, then I would kind of say it's probably some sort of reflex. I just don't know if it's carotid sinus hypersensitivity, if it's situational, or if it's vasovagal. So carotid sinus hypersensitivity is really interesting in the sense that if I I'd say provide the same kind of event that put them into that type of arrhythmia or that type of event, I could do what's called a carotid sinus massage. And if I do that, what it should do is it should kind of precipitate the body to think that the blood pressure is high, and it should drop the systolic blood pressure and drop the heart rate. So what I would see is a systolic blood pressure drop of greater than 50 or asystole for at least more than 3 seconds. And that's boom, diagnostic. If the patient has a prodrome, it means that they get lightheaded, they get nauseous, they get kind of dizzy, they feel like things are they're getting dark, and then they pass out. That's super suggestive of either vasovagal or situational. So think about it. Was there a situational experience? Were they coughing or were they peeing and then they were really forcing that and then they passed out? That's suggestive of situational. Whereas if the prodrome was present with them being in insane pain, or they just saw like a spider or a bear was chasing them, or they were standing for a long period of time, that's more suggestive of a vasovagal syncope. And if you're still not sure, you can sometimes do what's called a tilt table test, and that can sometimes be helpful in that scenario. But that's how we'd approach syncope. One quick thing is sometimes there can be this differentiating factor that you really have to discern. Did the patient syncopize or did they develop a seizure? Because sometimes it can be difficult. The reason why a seizure is you can lose consciousness. Syncope, you can lose consciousness. One of the differences here is that in seizures, you'll see tonic-clonic activity that usually occurs with this loss of consciousness, whereas you will not see tonic-clonic activity with syncope. You may see some type of jerky movements, but it should not be in this tonic-clonic fashion. The other thing is an aura. So auras are definitely present in seizures, whereas in syncope, you want to look for that prodrome if they potentially have a reflex syncope. And then lastly, tongue biting is more suggestive of seizures. It should not be present in syncope. And same thing, incontinence, losing control of bowel or bladder function is more common in seizures. It should not be present in syncope. Lastly, this postictal state after the patient seizes, they have this period of confusion, agitation. They don't remember what kind of happened, whereas in syncope, they have a transient loss of consciousness and they should be able to have complete remembrance or return of their consciousness with saying, oh yeah, I remembered what happened particularly. And that's what really would help us to classify syncope from seizures. When we have a patient who has syncope, regardless of the cause, whether it's reflex, whether it's, in this case, orthostatic or cardiogenic syncope, we really want to be able to treat these accordingly. So reflex syncope is potentially treating the underlying cause. In other words, avoiding any of those triggers that causes the patient to pass out. That may seem super obvious, but it's the obvious answer in these scenarios. Orthostatic is probably where you may get a question or two. And the concept behind this is remembering the cause. It's volume loss or it's decreased venoconstriction that's occurring here. So fluids can sometimes be beneficial if the patient is hypovolemic. Avoiding vasodilator medications, alpha blockers, or any other kind of drug such as a calcium channel blocker. This will be super helpful because if it's a vasodilating cause, you don't want to be having that medication on. And a patient who is chronically orthostatic for what may be a chronic like autonomic nervous system neuropathy of some sort, then in these scenarios, you probably want to put them on something that'll give them a little bit of squeeze to their vessels and help them to maintain fluid volume. So midodrine will squeeze their veins, and fludrocortisone will help to maintain a good sodium and water balance in the body. Last one is cardiogenic syncope, and it's pretty straightforward. Treat the underlying cause. For example, if they have an arrhythmia, they need an AICD or a permanent pacemaker. Right? AICD for VTAC or VFib, and then a permanent pacemaker for the bradycardia. And if it's mechanical, you have to treat that cause. Is it aortic stenosis, HCM? Treat the cause accordingly. All right, my friends, that covers syncope. I hope it made sense. I hope that you guys enjoyed it. And as always, until next time.